As far as today, Dr. David Ray practices internal medicine at Albany Med with a subspecialty in HIV medicine. Prior to Albany Med, he was chief of adult medicine and medical director of the HIV program at Whitney Young Community Health Center for 14 years. He is an assistant professor of medicine at Albany Med Division of HIV Medicine, and he has spent the last 36 years immersed in the science and politics of the HIV epidemic. Dr. Ray is currently the chair of the Capital District Alliance for Universal Healthcare. Topic for today's talk, and I give you Dr. David Ray.
As I started to say before, welcome humanists. I really appreciate that Don's organizing this and Fred inviting me, and the opportunity to talk to you about single-payer healthcare. I won't be doing any magic tricks today, so the magic has to happen for this outside of the system. I'd like to start by just talking a little bit about the healthcare monkey. The healthcare monkey is our addiction. Our addiction, one definition of addiction is continuing to use something when you know it is doing you harm. And if there was a better description of the healthcare system that we have now, I don't think I could think of it, because it is consistently doing us harm, and yet we don't seem to be able to separate ourselves from it. My own story begins in the 1980s when I first began practicing internal medicine. Among my earliest patient cohort then was a gay couple who had adopted a child, which was somewhat unusual 40 years ago. And they'd had negative experiences with some other physicians. I was apparently somewhat less judgmental, and they referred some of their gay friends to me. And this was just about the time that the HIV epidemic was emerging. The arc of my career followed the arc of the HIV epidemic, and I followed the demographics of the epidemic, ultimately moving from a suburban medical practice to the Whitney Young Community Health Center. In addition to working with marginalized and stigmatized people living with HIV that constituted most of the patients that I was seeing, I became aware of the health circumstances of immigrants, poor people of all races and ethnic groups, and the dilemma of the uninsured and the underinsured in our community and our nation. The health effects of our stratified and unequal system were very hard to ignore. The objectives of my talk today, I'll make this a little bit bigger. Can you see that okay anyhow? Read. The objectives of my talk today are three. One, to explain that healthcare reform is not only an issue of human rights and dignity, but it is an economic imperative for our country. Two, to convince you that proposed plans at both the federal and state levels are viable, comprehensive, and realistic. And three, having presumably convinced you of the need for reform, to give you some tools to allow you to have this discussion with friends and family, and to be able to respond to their questions and their doubts with research and fact-based information. I realize that this being the humanist society, probably I may be to some extent speaking to the converted, although probably maybe not entirely. And I've, over the years of pursuing my interest in this, what I've decided is that it's worthwhile to speak to the converted, because a lot of times the converted feel like they don't have the ammunition and the knowledge, ammunition is probably a bad word, the knowledge to be able to discuss this with people who they would like to convince or bring over to the side as advocates of single-payer healthcare. So no matter where you stand on the subject, I hope that you'll find this a useful discussion. With the passage of the Affordable Care Act in 2010, a lot of Americans thought our healthcare system was on its way to universal coverage, quality of access, and affordability. 12 years later, many people are scratching their heads and wondering what happened. However, to those of us who were following healthcare economics in 2000, even in 2010, we were already scratching our heads, because it was quite evident that bowing to the vested interests in the medical industrial complex was a prescription for the failure of the Affordable Care Act. I'd like to start with a couple of quotes. First of all, since this is a humanist organization, I thought a quote that was full of humility and humanity would be a good one. This is a famous quote from Martin Luther King. Of all forms of injustice, inequality in healthcare is the most shocking and inhumane. And then the second quote is one which is totally lacking in humility and is inhumane. And you can read that and you understand, you know the source. What I'd also like to say is that there's other ways besides humaneness to frame the healthcare debate. And I think that one of the things that has happened as the healthcare debate has emerged onto the public stage is that the vested interests have invested a lot in trying to change the nature of the argument. And one of the ways they change the nature of the argument is by saying that healthcare reform is a zero-sum game. And if I win, you lose, and if you win, I lose. And this is exemplified by this sign that was seen in front of somebody's house where he wrote, "Why is Narcan free to a dope addict, but my insulin is $750 a month?" The question is really, you're not being set up against the dope addict, if you want to use that term. The question is, why is your insulin $750 a month? So anyhow, this is what Obamacare turned out to be. And I'm sure if any of you have not tried to navigate this system, you're familiar with all of the circuitous and labyrinthine paths that you have to follow to try and get health insurance. It would be simple to follow the one on the right. However, I don't think that's the one we would choose. In fact, the failure of the Affordable Care Act, as I said, was really due to the fact that single payer was not brought onto the table. When Max Baucus was directing the hearings in Congress, a brave physician named Margaret Flowers from Baltimore, along with 12 other activists, spoke up from the gallery and asked why a single payer system had been taken off the table. Senator Baucus responded by having her forcibly removed from the Senate chamber by Capitol Police. Her and the group of 12 became known as the Baucus 13. They were, as it were, slapped down by the invisible hand of the market. But the question truly is not, can we afford to enact healthcare reform, but rather, can we afford not to? In the United States, the healthcare industry constitutes 18%, or at this point, closer to 20% of the GDP, as opposed to Canada, where it consumes around 10% of the GDP, with similar numbers in America's other major economic competitors. What could we do with the 10% of our nation's annual expenditures if it were not being burned up in a wasteful and inefficient healthcare system? Most estimates of healthcare expenditures ascribe fully 30% of them to unnecessary costs that do not contribute in any way to the health of individuals or the population as a whole. These costs include multiple middlemen, such as pharmacy benefit managers, insurance brokers, and insurance agencies. And I think that this is one of my favorite slides about the healthcare system, which shows in the past 40 years, almost 50, the growth of managers and administrators in the healthcare system as opposed to the growth of physicians, which we could really expand to say the growth of all providers. And it's clear that we have way more drivers and fewer horses than we need. There are hyperinflated costs for drugs, medical devices, hospital charges, and medical procedures, all of which are incredibly opaque, even with recent laws which have been intended to make them more available and understandable to the average, quote, healthcare consumer. The cost of governance and administration as part of our GDP, again, another way of looking at how expensive this system is. We're spending more than twice and sometimes 10 times as much as other countries on just the governance and administrative costs of healthcare, the healthcare system alone. This is not, and there are many other forms of waste in the system. In the Affordable Care Act mandated that HMOs and other healthcare entities needed to maintain a overhead that is the money that was being spent not on healthcare at less than 18%. But even 5 years into that law, there were still large organizations that were spending a fifth of the money that they were receiving in premiums and from government sources on administration, profits, and non-healthcare related expenditures. What they call the money they spend on healthcare is called medical loss. Medical loss means that's the money they're losing to take care of people. And as far as they're concerned, it's a loss. These are tiny, these slides unfortunately are a little tiny right here, but basically these are just examples of the kinds of income being made by the CEOs of some of these major healthcare organizations. And as you can see, those millions and millions of dollars would probably be better spent on other ways, like healthcare. Just for comparison, compared to that 20% of overhead in those HMOs, Medicare on average has an overhead of about 3 to 5%. So all of these players have very deep pockets, and they've reached into those pockets to pursue every possible legal avenue to oppose healthcare reform and to blanket the media with lots of misinformation and outright falsehoods regarding the nature of a single-payer system. I'd like to take a few minutes to go through some of those myths, which I'm sure many of you have heard, to try and dispel them with at least a little bit of factual information. The first myth, that single-payer healthcare would be too expensive. Well, you've already seen what a large chunk of our GDP it occupies. And in fact, 2/3 of healthcare spending already comes out of taxpayers' pockets. And you can see the breakdown here in terms of tax subsidies, which go to employers to help them pay for health insurance for their employees, government workers on the federal, local, and state levels, all of whom receive health care from tax dollars, other single-payer healthcare systems that in the United States, like the VA, public health, the Indian Health Service, and even the program under which I've worked for most of my career, which is the Ryan White Healthcare Act, which is money exclusively devoted to the care of HIV patients, and is essentially a single-payer system. Medicare and Medicaid, of course. So 30% of the healthcare spending is coming from private sources, from the insurance industry, et cetera. And if you think about what I said before, that probably 30% of the money that we spend in this country is waste in terms of overuse, abuse, profits, and cost of administration. We could get rid of that 35% of money that's coming from the private healthcare industry, and we'd still have the same healthcare system. We'd actually have the healthcare system that we're paying for, as opposed to paying for all these extraneous costs. So a single-payer healthcare system eliminates free choice in the healthcare market and eliminates the efficiency created by competition. Well, anybody who participates in any form of private healthcare, and that would include people using Medicare Advantage, which is another discussion that we could have, or people may have questions about Medicare Advantage. You know that you don't have free choice. You're given a panel of physicians who you are allowed to see. You're given a panel of a limited menu of what medical care you're actually eligible for, what hospitals you can use, and a formulary for medication use, which may change from year to year, which is an important thing, because the way those formularies are devised is by deals made between the pharmaceutical industry and the insurance company. And if the insurance companies decide that the cost of your cholesterol medicine is too high, at the end of the year, they just say, you're being switched to another cholesterol medicine because we won't pay for that one anymore. So it really is not in the interest of patient care, but simply in the interest of cost. In terms of free choice, this is a somewhat older slide, but it's still applicable, and possibly even more applicable now as rural and small town hospitals have closed over the past 20 years. Half of Americans live in a place where the population is too low for competition. There's no restraint on local healthcare facilities in terms of what they're going to charge if there's no one else in the community that the patients can go to. For many women in America today, they have to travel 50 miles or more to find obstetrical care for deliveries. Healthcare myth number 3, Americans will never accept a single-payer system. Not if it's mislabeled socialized medicine. which of course a single payer system is not. You might possibly say that the system of the National Health Service in England is socialized medicine, where the state owns both the hospitals and pays for the physicians themselves. But the plans that we'll be talking about in the United States maintain the current independent nature of hospitals and medical providers, and the state does not own them. It's just a way of paying for it. Polls over the past 20 years have shown consistently that there is great support for a single payer system, either replacing the Affordable Care Act with a federally funded system, which is popular, overwhelmingly popular both among Democrats and even among a selection of all adults who are polled, and expanded universal Medicare for all. And this is from a Kaiser Health study. Again, looking at about 60% of the general population and independents who favor a single payer system, and even 30% of Republicans. Just another way of looking at the same numbers. The fourth myth is that unacceptable delays in receiving care will inconvenience and possibly cause harm to patients. And this is one of the ones that was trotted out on television and in advertisements when the Affordable Care Act was being debated, that you'd have to wait so long that you might never get the procedure that you're hoping to get. Well, in fact, studies, although this is a difficult thing to study because it is to some extent comparing apples and oranges in multiple systems, but a Commonwealth Fund study done in 2017 showed that basically, at the very worst, single payer systems are not worse than us, and are not worse than our accessibility and time to getting to see providers. 51% of US patients reported being able to see a provider within a day, compared to 53, 56, 67 in these other countries. 30% of US doctors reported that their patients have difficulty getting a specialized test. 4% of the patients reported waiting 4 months or longer for non-emergency surgery, compared to, for example, 0% in Germany. And for specialist appointments, 6% of US patients reported waiting 2 months or longer, compared to 4% in France, 3% in Germany. Now, somebody might look at this and say, well, maybe the people who are waiting so long are the people who are on Medicaid. And that in fact might be true, because we have a 2-tier or possibly 3-tier, maybe you'd even say a 4-tier system, because there are people who have insurance, there are people who are on Medicare, there are people who are on Medicaid, and then there's people who are uninsured. If you're unlucky enough to be uninsured in this country, you might never get the service that you're waiting for. You might die waiting for it. And if that's acceptable, then it's certainly possible that these numbers don't mean anything. For people who are well insured, their waiting times may be as good as some of these other countries. Doubtful that they're a lot better. Myth number 5, that doctors are opposed to a single payer system. We know that doctors are financially doing as well or better under the Canadian system. And also we know that doctors, even doctors in this country under the current system, largely favor a single payer system. This is a 2018 Medscape poll, which Medscape has a fairly large, broad spectrum of medical providers that are members. 68% said they supported, with 52% strongly supporting moving to a single payer system, and 21% said they were strongly opposed. I don't think that Medscape identified who those 21% were, but chances are they are the people who are doing extremely well under the current system, because that tends to be, in all situations, who favors the status quo. And there are a number of subspecialties where physicians really make a lot of money. But in fact, the Canadian system compares quite well. This is, again, a somewhat older slide, so that as my next slide will show, the numbers, if anything, have improved. These are fee-for-service billings for Canadian physicians, which, having looked at the numbers for similar specialties in the United States, are not substantially different. And it's really interesting because what you have to consider is that if that's your fee for service billing, your gross, in America, you have to, all of these different medical providers have to pay for people to negotiate with insurance companies, have to pay for administrative overhead to deal with the current system. And so their take home is is substantially reduced by that, as opposed to a physician in Canada who basically has one biller who sends a bill to the Canadian Medicare system, it's called Medicare there, and gets paid without any arguments and without any doubt and in a timely manner. And as I said, the trends in Canadian physicians' incomes have been consistently upwards for the past 40 years. I think this is a very telling slide because, and there may be multiple reasons for this, but nonetheless, there's twice as many applicants for available medical school places in Canada as there are in the United States. Promising students in Canada don't look at the field of healthcare and say, it looks like too much of a hassle. I think I'll just be an investment banker. We are losing a lot of promising young people who could go into the healthcare field, and not just as physicians, of course, but as nurse practitioners and physician's assistants. All of these people, I have to say, I work with nurse practitioners and PAs, and they find that the hassles of the system are just as daunting for them as they are for physicians or for anybody else really working in this current system. Healthcare myth number 6. Pharmaceutical and other healthcare innovation will suffer under a single-payer system. Well, most new pharmaceuticals, in fact, are invented by research, or come from research that's funded out of your pocket. Most of the basic research is done at government institutions, places like the Wadsworth in New York, or the medical centers. And then what happens is the pharmaceutical industry buys the information, the knowledge, once that breakthroughs have been made, takes a patent out on it, and for the next 17 years markets it. And that's what they really spend their money on, is marketing and lobbying and increasing their market share. Studies have shown that over the past 30 years, on average, fewer than 2 major clinical advances, and at best 7 to 13 superior drugs were developed each year, compared with 85 to 90 drugs that are developed as what's called, quote, Me Too drugs. Drugs that the pharmaceutical industry cooks up because they're running out of a patent, and so they change a small portion of a molecule, and they have a new drug that they can market, which is really not substantially different from the old drug that they were selling. The main reason that the new drug was brought out was because of the loss of patent and loss of market share. And as a result, U.S. drug spending has gone through the roof. And every one of us is a victim of this, partly because even people who are on Medicare, who you would think should not have to go broke out of pocket trying to pay for their medications, are subjected to the fact that Part D Medicare was specifically negotiated to forbid negotiations between the huge Medicare population. 60 million people represents a big market share. And so basically the vested interest said, well, we don't want to have to negotiate for 60 million new customers. So you can't do that. And Medicare Part D specifically excluded the right for the government for Medicare to negotiate on pharmaceutical prices. And the pharmaceutical industry is by far the most profitable segment of the healthcare industry. And as I said, what they don't spend on marketing, they spend on lobbying. At least 50% of pharmaceutical income is spent on either, besides going for profits and administrative costs, goes for lobbying and marketing. And this is unfortunately a fairly tiny slide right now, but you can see that looking at these this is the top, I think, 20 healthcare lobbying organizations. Very top, Pharmaceutical Research and Manufacturers of America, also known as Big Pharma. And then as you go down the list, you can see Pfizer, Roche, Merck, Amgen, Novartis, Gilead, AbbVie, Eli Lilly, Johnson & Johnson, GlaxoSmithKline. They're the big lobbyists, and they spend freely. Last, and possibly the saddest thing is that we believe that the myth is that we have the best healthcare system in the world, and that people flock from all over the world to get their healthcare in the United States. Well, if that's true, why is there such a thing as medical tourism? Why are there ads all over the internet that people read and actually follow through on to go to Mexico or Brazil or Thailand to get medical procedures at a fraction of the cost they would have to spend in the United States? And these are major procedures like joint replacements. There are people who research this and find a cheaper way to do it. So, number one, we're certainly not the cheapest, and the care that people get in these other countries is usually equivalent to the care that they get in this country. But more telling is the lag in life expectancy that has emerged over the past 30 years between our country and the other developed countries of the world with single payer systems. And this is shocking and embarrassing. And it's totally unacceptable that we should not be maintaining. And in fact, as you're probably aware, as a result of the pandemic, plus the recent opioid epidemic, and what they call deaths of despair in this country, American healthcare or life expectancy has actually been dropping over the past 4 years. This is a World Health Organization ranking of different healthcare systems. The 11 most highly developed countries, all of whom except for us have single payer systems. And all you have to do is look at the right to see that under access to care, administrative efficiency, equity, and healthcare outcomes, the United States is dead last in every one of these rankings. So you might say, well, wow, how come we're second in healthcare process? And I can explain that. And it's basically due to the nature of the insurance industry. Healthcare process means the protocol or algorithm that's used to manage patients when they're sick, and particularly when they're in the hospital. The health insurance industry has been in the forefront of creating algorithms and protocols intended primarily to get patients out of the hospital as fast as possible. It's not necessarily a way of improving healthcare outcomes. In some cases it is, and I wouldn't dispute that. But in many cases, patients are discharged, and I see this as a practicing physician. Patients are discharged from the hospital before they're ready to go. They may bounce back because they were discharged too soon. And now there's a new movement afoot by the insurance and the American Hospital Association to create an aftercare program where patients can be discharged even sooner and essentially receive hospital type care at home, which is bad in so many different ways that you can hardly begin to enumerate them. Just using one example is maternal mortality. And maternal mortality is a very good proxy for the deficiencies of a healthcare system, because maternal mortality is determined by three things. One, the health of the woman before she becomes pregnant, and whether she has unaddressed medical conditions, diabetes, hypertension, other things, which if she's uninsured or underinsured, she may have been avoided getting care for. Then when she becomes pregnant, the question is, does she have access, if needed, to high-risk obstetrical care? Does she have access to obstetrical care at all? And is her obstetrical care limited in some way, or her prenatal care limited, and her perinatal care? And then the other thing is the 3 months that maternal mortality includes the 3 months after a child is born, because if you're diabetic before your pregnancy and you're diabetic during your pregnancy, you're diabetic after your pregnancy. And if you don't have adequate medical care, it increases your likelihood of dying from the same morbidities that you had prenatally. So why single-payer Medicare for all? As I've talked about before, one thing is universal coverage. Commercial insurance does not cover everyone. And many people, if you have not personally run into this, you may have family members or others. They're afraid to change their jobs. They're afraid to move. because they might lose their health insurance. And one aspect of any job search always seems to be, what kind of health insurance am I going to get? Is it going to be adequate? Will it cover my family? Will it cover my spouse? Medicare for all, everyone is covered. Medicare for all, everyone is covered from birth till death. You get a card at birth, and your card works until the last day of your life. Medicare for all would cover all medical needs, all medically necessary services, as opposed to the menus that we unfortunately always have to deal with commercial insurance. Well, you're eligible for dental care, maybe if there's a dentist that takes the dental insurance that we're offering, or maybe we'll pay 10% of the cost of your glasses. It's pretty limited. And as I mentioned at the very beginning, free choice. There's Medicare. If you have a Medicare card, you can go any place in the country, and generally you have pretty good chances of finding physicians that will accept your Medicare and hospitals that will accept your Medicare. It's unlikely that you would go anywhere that Medicare would not be accepted. Medicaid is different, but Medicare is certainly totally portable. And as I said, there's a business argument for this. Here's a list of the ways that a single-payer system would strengthen American businesses. The cost of the healthcare benefits are reduced. Healthcare benefit management costs essentially go away. Extraneous insurances that we have to cover all the gaps, like workers' comp and auto and liability insurance. And also the continuing need for employers, which we've seen even locally with GE and other major corporations, the battle going on over maintaining retiree health benefits. And it reduces employer risk because there's predictable future healthcare costs. It eliminates the risk of having an employee who suddenly develops a severe medical condition that may bankrupt the employer's insurance or cause them to have incredibly high increases in their rates. And it eliminates one of the major contentions in labor negotiations. So, as I said, national health insurance. It covers everyone. It's comprehensive. There's a single payer. There's no profits to be made. There's improved population-based healthcare planning, and there's public accountability for quality and cost. I'd like to spend a few minutes just looking over the Medicare for All Act of 2021, which is currently sponsored in the House by Representative Jay Powell and in the Senate by Senator Sanders. Has been on the docket, has been under consideration for a number of years. It's not a new thing, but it's been updated as of 2021. It builds on and improves on previous bills, like all the previous bills, and that mentions the things that we just talked about: global budgets, no copays, equitable tax funding, comprehensive coverage. And what's new is there's more investment in health equity. I think that this is something that, if anything, has grown out of the pandemic, because what we all witnessed was the incredible inequity brought out by that healthcare emergency, whether you survived COVID, especially in the first year and a half, depended upon whether you're insured, where you lived, what hospitals you had access to. There are more covered benefits in the new bill. There's a prohibition against any future benefit cuts. And as I said, it prepares the nation for future public health emergencies. And these are all the things that are covered by the law when it's enacted, including outpatient, inpatient, prescription drugs, without copays, without co-insurance, without deductibles. You present your card, you get the services that you're there for. Nobody is left out, and that includes anybody residing in the U.S., regardless of age, income, employment, or immigration status. And it's as I said, you get your card at birth, and it's yours until you exit. No one is denied due to pre-existing conditions, and there's free choice. I will make one small point here, which is that sometimes people will say, well, immigration status. So does that mean that people who are undocumented are eligible for Medicare for all? And the answer is they should be, because we're all in the same boat. If people who are undocumented live in this country and get sick, they're going to go to the hospital, and you're going to pay for it, because the hospital is going to pass along those costs to everyone else, and it's going to come back to us who are paying taxes and for paying for healthcare insurance. Number one, this is aside from the humane arguments of everyone should be entitled to this care. Number two, that those people, because they may not have been insured before, when they get to the hospital, they're going to be sicker, they're going to be more expensive. And number three, as I said, we're all in the same boat. If someone is in this country and they have a communicable disease and they've come from another country, if they're not getting treated, they're only going to be a source of infection for other people. So there are many reasons, public health and economic reasons, that everyone should be covered, including those that we call undocumented. And this is somewhat redundant, but it says that, lack of co-pays, no paperwork, covers virtually every source of healthcare that you might need, and it's comprehensive coverage without having to purchase Medigap or supplements or Medicare Advantage. Medicare Advantage, again, being a huge problem for the current Medicare system, and I'd be happy to talk about that if people have questions. Administrative efficiency under the proposed act, eliminate the waste and the profits of commercial insurance, and making it possible for doctors to operate and providers to operate offices without having to have one or two billers for every provider in the office to negotiate with the insurance companies. Global budgeting for hospitals is also a part of the act, and there's basically the reason for this is that so much of hospital expenditures now is really based on capital expenditures to build these beautiful buildings to try and attract people from the hospital down the street. Our ICU is prettier than yours. Our emergency room has nicer paintings on the walls. You ever walk into any of these, any real major healthcare institutions, what you'll see is paintings and artwork, which contribute very little to the nature of the healthcare. Maybe it's nice aesthetically, but we need to put our money first into care. Then we can worry about window dressing. And as I said, promoting healthcare equity. There are several systems which would be carved out in the sense that people who are in those systems and get special services or need special services or have special hospitals of their own would not be forced to use other public hospitals. And that includes the Indian Health Service, the Veterans Administration, and TRICARE, which is the military healthcare system. And this is just a list which is fairly obvious of all the subpopulations in our country who are people who are impacted by unequal healthcare. This is a list of some of, as I mentioned, there are some new benefits in the current law, and these are some of them, and the protected populations that I just reviewed. Another question that comes up is, what about the transition? And what about those, if 20% of our economy is the healthcare system, what happens to all the employees of the insurance companies and so on? And the answer is that this bill has in it provisions to help people transition from the current system to the new system. Those people would still be needed. We'd still need a lot of people to help who understand how to administer a healthcare system, maybe, but just not as many. The CEOs, I think they can take care of themselves. They have their fairly large bank accounts. The other thing to consider about who works in the healthcare insurance industry is that there's a lot of medical providers. There are doctors, there are nurses, whose job it is right now to spend their time reviewing the work of other doctors and nurses and deciding whether anybody should get paid for it. I think it would be better if those people were giving direct care as opposed to trying to prevent others from getting paid for the care that they've given. There is a 2-year implementation plan in place, which I can go back and look at this if people are interested, but basically it allows a transition first for people who are already on Medicare to get to the expanded Medicare, and then for people to buy into the new Medicare after the first year, and in year 2, transitioning to Medicare for all. Again, just comparing, what a single payer system would look like in this country as opposed to, if we using Canada as the model. They have a longer life expectancy. They have lower infant deaths, lower maternal mortality, universal coverage. In fact, people feel much more free to go to the doctor and get their problems taken care of before they become serious. Quality of care and access is equivalent to Americans. There's free choice of doctors and hospitals, and it costs half as much. I have a couple slides that were from the Rand Corporation study done in 2018, looking at the New York Health Act, which many people support as an alternative to national health care, because the feeling that, just like it happened in Canada, the single payer system in Canada started first in Saskatchewan. It started in one province, and then the other provinces realized that they had to have it to keep up. And so there is an argument for saying maybe getting a couple states to start offering this would force the rest of the nation into a reckoning. And basically what the RAND study showed is that over 10 years, if following the implementation of the New York Health Act, there would be about $80 billion in savings, or about 2%, which would accrue to continuing with, as compared to continuing with our current hodgepodge system. And of course, as time went on and the system became more efficient, that would actually increase. I hope that this outline of the rationale and reality of a single payer system has answered questions that may have been on your mind. I also sought to dispel some of the myths created by the misinformation machine funded by the vested interests. And lastly, I'd like to provide you with a few sources or resources for further study to enable you, if you are interested, to become advocates for healthcare equity. So this slide, I don't know if there's a way that this will be in the recording. I don't know if there's a way that we can get this for people to, you do screenshots, I suppose. I put 6 things up here, and they're different. They have different ways of looking at the healthcare reform. The Campaign for New York Health is a campaign solely focused on trying to get the New York Health Act enacted. That the New York Health Act has actually been proposed in one form or another for more than 25 years. And actually, Richard Gottfried, who is a assemblyman from New York, is retiring this year. He has been the lead sponsor for the past 25 years. We were hoping that we could gift him with the passage of that law this year. Didn't happen. That doesn't mean it will never happen. PNHP is Physicians for a National Health Program, which is a organization of more than 60,000 physicians nationwide who support a single payer system. It has very detailed explanations of different aspects of healthcare inequity, of what's happening on various legislative fronts, and it's a very comprehensive source of information. Arm and a Leg is a podcast which I have been listening to for a couple of years, and it's actually just worth it. It's worth listening because it's funny and it's inspiring, but it also points out the problems with our system. This is a reporter named Dan Weissman who was I think a New York Times reporter, and basically what he does is he looks at different aspects of the healthcare system and how people figure out how to avoid becoming bankrupt and ways of circumventing the costs of and the trials and tribulations and complications of our system. And the maneuvers that people make are really amazing, and it's worth listening to that. Dr. Donald Light is at the Harvard Forum on Healthcare Ethics, and is also a professor at Princeton. And he is an amazingly well-informed and articulate spokesperson regarding the pharmaceutical industry. And he really understands the ins and outs and the economics of the pharmaceutical industry, in case you're interested in a little more expansion on what I've already talked about. As Fred mentioned, I am the chair of something called the Capital District Alliance for Universal Healthcare, and there's our Facebook page. We're an organization which advocates for single-payer healthcare, and we've been doing various sorts of promotions around the Capital District for nearly 20 years, showing movies, setting up tables for information at various events. And if you're interested in joining us, if you join on through the Facebook page, I will be happy to put you on our mailing list. The last reference I have here is a movie called Fix It, Healthcare at the Tipping Point, which was produced by a businessman in Pennsylvania when he realized that his company was going to go broke trying to finance their the healthcare needs of their employees. And he became a very vocal advocate for single-payer healthcare, and he's produced several documentaries which have very high production quality, are really interesting and full of information, and they're very concise. And I would strongly recommend going to fixithealthcare.com and watching one or more of his documentaries. And that's it.
Great. Dr. Ray, thank you very much. That was very interesting. I do have a few comments and questions in the chat. I am going to pull down your screen share so we can
Sure.
do with that. First off, we did have a question from a comment early on from Michelle Vick when you had the slide up about the growth in doctors versus compared to the growth in administrators, and she commented, just saw the problem. Too many chiefs and not enough Indians. It's unreal how so many college graduates jockey for administrative positions expecting to be above the hierarchy in a month.
Yeah, there's a cartoon that I had on my office wall many years ago, and it's a picture of a stagecoach stuck in the mud. And there's a couple horses pulling the stagecoach, and there's a driver on top with a whip. And then it has two frames after that. It has one is called the one solution, and it has 6 horses instead of 2 horses pulling the stagecoach out of the mud. And the other one is called the administrative solution, where there's the same 2 horses, but then there's 10 people on top with whips whipping the same 2 horses to get the stagecoach out of the mud. And that's pretty much the way it's felt for the past 40 years.
Mm-hmm. Okay, Andy had a question here about what is your view on hospital consolidation, with locally now being only 2 groups, one Trinity not even based here. Trinity claiming not enough profit needs to lay off employees in the St. Peter's group and consolidate some aspects with its Syracuse unit. Does Medicare reimbursement rates have any responsibility for this?
Well, what this is really about is competition for profit. And just because places are quote nonprofit doesn't mean that they aren't about the bottom line. This is the same reason that the Medicare for All plan includes global budgets for hospitals, because most of the expenditures that they're trying to keep up with are expenditures on window dressing and duplicate facilities. There's very good data and evidence that we have way more MRIs, for instance, in a place like Albany than Albany really needs, and dialysis units. There's things that are high profit. These hospitals will invest in, and in order to be able to have the bankroll to invest in them, the best way for them to do that is to buy up other hospitals. So instead of competing with them, they're siphoning off the profits of the other hospitals to use for capital expenditures and beautification. And beautification doesn't just mean putting artwork on the wall. It means making the place look fancier. Everybody wants to be at the Mayo Clinic, so every place wants to say we have the same beautiful suites and well-appointed patient rooms as the Mayo Clinic.
Mm-hmm.
So that's really what the consolidation is all about. It's about consolidating the profits.
Okay, so in other words, follow the money.
Yeah.
Look for the money. Michelle Vicks had a question I think you touched on, but just to reiterate, don't other taxes such as gas compensate for health care? I think you raised, Phil, you raised that point when you were talking about how healthcare costs some of them are hidden in some of the other taxes and fees we pay regarding whether it be insurance payments for automobile liability.
Right. Well, I mean, actually, what that was really saying was that what the point there was that we don't need those insurances. If everybody had a card that said, I'm entitled to the medical care I need. If you're in a car accident, you get the medical care you need. You don't have to appeal to the other driver's insurance company. You don't have to go through that kind of a fight. You get them. And that cost, which, if you look at your health insurance, that liability is a big chunk of, your auto insurance. That's a huge chunk of your auto insurance. And if you take that away, then you basically have to pay for broken glass. And the same goes for workman's comp. If every place of employment didn't have to be spending money paying for workman's comp insurance, workman's compensation, if every employee just had health insurance that covered them, if you fall at work, or if you get your finger cut off, God forbid, your health insurance takes care of it. It's not a worker's issue, it's a health issue. It's not an employer's issue. The employer should not have to pay for your health care. And, on the subject actually of healthcare through employment, in 1980, 80% of people's health insurance was coming from employment. That's now less than 50%. In other words, basically employers, many people who work and change jobs, people you discover, there are many employers who no longer offer healthcare insurance. That's one of the reasons the Affordable Care Act had to be enacted, because so many people were paying out of pocket didn't have the means to get health insurance because employers are dropping it. And there's no reason to think that if we've gone in the past 50 years or 40 years from 80% of employers to 50%, that it's going to go back up. If anything, employers are less and less inclined, because it's as I showed in the slide, it's a problem with labor negotiations. It's an unpredictable cost. And there's so many reasons that it's a huge burden for employers, and it basically lowers their competitiveness. There was a quote, a famous quote that I can't tell you the exact person. It was the vice president of General Motors for their Canadian subsidiary. And he actually said, General Motors is very happy to be in Canada because we do not have to worry about paying for health insurance for our employees here. And that was the vice president of GM.
I've heard that similar thought expressed. I don't know if it was from the same source or not, but companies were unwilling to come to the U.S. in some cases or more willing to go someplace else because if you go someplace else, you avoid the healthcare cost. Speaking of other countries, I had a question that came up to my mind when you were talking about the proposed Medicare for All Act and dealing with providing care for regardless of immigration status. And my question is, how do countries with single payer systems deal with non-residents that need care while in that country? Like if I were to be in France and I needed care, would that?
Usually you are subsumed into the system. I've had, one of my experiences with single payer healthcare was in Costa Rica, where I was traveling, and my son managed to do something to himself to smash a tooth. And we found a dentist in a small town near us, and we went in and he did procedure, took care of the broken tooth, told him that he'd have to have a root canal at some point. But then when we were done, I said, and how much do we owe you? And he said, nothing. Healthcare in Costa Rica is free.
Great. Andy had another question. Under the single payer system, do you advocate eliminating all private pay for service to medical provider?
No. Basically, the Medicare for All would be a comprehensive system that would pay for all medically necessary care. And what's medically necessary would be determined by a board of supervisors, probably that would be regional, that would consist of providers and patient advocates and other members of the public and government officials that would meet and decide what is necessary and how do we need to expand our care in this region. But that would not include certain things like cosmetic surgery, or there are other things that would almost certainly be excluded as not being medically necessary. And in Canada, people are allowed to buy supplementary insurance to cover those things. And there'd be no reason that wouldn't be the case in the United States also. It's really true in many of the single payer countries that have single payer, that if you have the means and you want to pay extra money for services that you may or may not need, you're free to do it.
Karen Kaufman had a question. Did you say passage of the New York Health Reform Act would save 2%? What do you mean by that?
2% over the expected expenditures. I could go back to that slide, but basically it's over the expected expenditures in the next 10 years. They said that the Rand Corporation determined that the expenditures would be 2% less over just the first 10 years. In other words, if we kept with the system we have now, it would cost $80 billion more over the next 10 years. Obviously, and based on their study, they anticipated there would actually be growing savings beyond 10 years.
Carol had a comment. Thank you, Dr. Ray. Extremely timely and interesting. Michelle Vick's meant to clarify something. I think I meant in other countries. How will they keep costs low?
I'm sorry. Say that again.
Okay. Michelle Vick's comment is, I meant in other countries, how they keep their costs low.
Well, the answer is that first of all, it's really important to understand that they're not all the same system. Our Medicare for All, what Germany has, Germany actually has several consortiums of private insurance that are regulated by the government, but they are regulated to the hilt. So they cannot change premiums, they cannot refuse patients, they have to offer the same menu of care. So essentially, it's privately managed Medicare for All, and they're all nonprofits. And that's the way the Germans have arrived at it. And as I said, in England, they have the National Health Service, where the country itself, the national government, owns the hospitals and pays the providers directly. There's many various iterations of this, but all of them basically boil down to systems where there's a single funding stream, where it's highly regulated, which of course is a bad, it's a word we don't say in the United States. Regulated, it's highly regulated, so that people, whoever you are, you receive the same care, you have the same access to care, and the same quality of care, and do not pay differently than anyone else, and you have no extra out-of-pocket costs, at least for the base care. Like I said, certainly people are allowed to buy their way into something fancier but the essential spectrum of care is available to everyone at no cost.
Okay. Eugene had a question. What would be the arguments for and against expanding the current mixed/regulated systems versus transitioning straight to single payer?
Well, we've tried to do that. That's what we're doing now. But it's working actually in the opposite direction. I mentioned Medicare Advantage. So what's happened with Medicare Advantage is that Medicare decided that they would let certain private entities like HMOs have the amount of money that they would spend on a given individual. The private companies get that money to hold on to pay for the care, and then the patient contracts with the private companies. And what the private companies do is they try to sweeten the pot by saying, oh, we'll give you some vision care, and we'll give you a gym membership, and we'll give you, this thing and that thing. But you're going to have a restricted menu of doctors, so you won't be able to see every doctor, and your insurance won't be portable. And by the way, if you have certain medical conditions, you will be paying more. And if you're on more medications, you will be paying more. And what they've done is they've actually created a system, which is what the private companies are very good at, of what's called cherry picking. They entice the patients that are least likely to be expensive so that they can make the maximum profit. So the government gives them X dollars for a 65-year-old in Albany, New York, and they say, let's find all the healthy 65-year-olds in Albany, New York, and let's enroll them, and then and they'll only cost Y, and we'll be making X minus Y a profit. And let's make sure that we don't enroll all the unhealthy 65-year-olds in Albany, New York, because their cost will be Z, and that will be greater than the X that we're getting from the government. We don't want to spend more to give them the care. So it's, that's the problem with setting up a system that's a hybrid, is that the private entities will find ways to game the system. Oh, and then there's other things they do. They do something called they inflate bills by what's called upcoding, and they direct doctors who are seeing patients under these Medicare Advantage programs to upcode. In other words, they're told, you need to add all the possible codes you can to any care process that you're giving to a patient, so that we can charge for multiple care, charge Medicare for multiple different kinds of care, even if it's all part of one process.
Okay, we have a few people raise their hands, and we'll start going through those. Karen Kaufman, can you unmute yourself and ask your question or comment?
So I believe I heard that in the current Congress, there was once again a proposal to allow Medicare, Medicaid to negotiate drug prices with the pharmaceutical companies. And it was expressly voted down again in Congress. And I just view this as evidence that, the moneyed interests still have an iron grip on Congress. I mean, it's just to me, that is just such a no-brainer, right? That they can't even they can't even make that small step to reduce our healthcare costs. I just like to hear I'd like to get some hope from you.
My feeling is, I've been at this for 15 years or more. That ultimately, the only way we're going to overcome the money that the vested interests have to invest in protecting their own interests is by making our representatives more concerned that they might lose votes over this. Okay, and the only way you can do that is by building a grassroots movement, and it can happen, and it has happened with other things in this country's history. It's not a lost cause. It's a long-term cause. We are not, when I think about, is single payer going to help me? Certainly not in my career. My career is, I'm in my sunset years. Will it help my daughter, who's a pediatrician? Maybe, although she's already figured out how to avoid it by going to work for the Indian Health Service. The answer is, though, that number one, the general population has to be better educated, and number two, we have to get as many medical providers on board, which is why there's an organization like Physicians for a National Health Program. There has to be pressure coming from the various constituencies that are involved in the healthcare system on elected representatives. And as Fred said in the beginning, I am on first name terms with Jay Jochnowitz, who's the head of the opinion page at the Times Union, because I've sent him so many letters on these subjects. And that's the answer, is that we have to just make ourselves heard. We have to try and continue to educate one another.
You recommend that people actually bring up the subject with their own physicians?
I don't see why not. I mean, you may have more pressing issues to discuss with your physician than healthcare financing, but it certainly, you could ask a physician, what do they think about it? I think that you will probably find that certainly most primary care physicians are going to say, I think it would be a better system.
Okay. Andy, you had a comment or question?
Yeah, if I recall, a few years ago, Vermont implemented a single payer system, but shortly aborted the single payer system. Do you recall, or do you know anything?
Oh, I know. Yes, I'm very familiar with that. The problem in Vermont was several. Number one is it was still a somewhat hybrid system that was going to allow some private entities, particularly hospitals, to remain independent of the system, so they wouldn't be subjected to the global budgets that we talk about in the Medicare for All. And so the the reason they said it would be unsupportable because, of course, the hospitals are a bottomless well of need when it comes to expanding their facilities, whether or not it's medically necessary. They also did not do a very good job of doing what the New York State, the New York State has looked into in terms of the people that support a plan in New York, which is getting what's called waivers, okay? Because you have to have waivers from the federal government to allow Medicaid and Medicare money to be rolled into the single payer system. And the RAND Corporation looked at this and they said, even in New York, without getting those waivers, because of the way the bill is structured, we would be able to use the Medicare and Medicaid money for the New York Health Act to finance the New York Health Act. So, Vermont made a couple of mistakes because, just like the Affordable Care Act, unfortunately, the vested interests had a voice. The hospitals being a very potent vested interest, they had a voice in the Vermont legislature, and they prevented certain provisions from being in the act that would have made it actually financially viable.
Okay, thank you. Michelle Vicks had another comment here in the chat. She said, my brothers contend that excessive government regulation drives up costs as well as undermines quality of care.
Well, I mean, as I said, the example, the living example we have is Medicare. Medicare has a 3% overhead as compared to most of the private industry, most of these private corporations, which have overhead of 15 to 20%. And what is that 15 to 20%? That's money that's not being spent on healthcare. Medicare is spending 95 to 97% of its dollars on the care of its subscribers. It's certainly quite a myth to say that bureaucrats that government bureaucrats are worse than private corporation bureaucrats who are doing the same thing. We deal with them. If you're in practice, you deal with them every day. There are so many times that I have to do something that is clearly an approved medical service, and I'm told the insurance this person has won't pay for it. Then I have to make an appeal. Then I have to wait for somebody to call me back so I can explain to them why this is important. And I've actually, I'm an internist. One of my favorite examples was, that we started that the Public Health Service recommended screening people who are long-term smokers for lung cancer with CT scans after age 55. First time I ordered one, I had to speak to somebody who was clearly not an internist. And this person had no idea that this was now considered to be a standard of care. And when I ordered it, and therefore they'd said, oh, you have to tell us why you want to do the CT scan. I said, because it's what the U.S. Public Health Service Task Force has recommended. So, you're dealing with bureaucrats who are ill-informed in the insurance industry.
It's not on their list of approved procedures that are generated to save the insurance company money.
So, I mean, I understand where that discussion comes from. And yes, it's certainly true that the government can be a behemoth that's slow to pivot to needs. Private companies seem to be faster to make changes and pivot, but usually what they're pivoting to is changes that will increase their profits.
Yes, okay. Fred, you had a question or comment?
I guess I have a couple of comments. Number one, I appreciate everything you presented, very helpful, insightful. And I think, as you mentioned, it's going to take a massive grassroots movement pressuring politicians. Years ago, I knew a fellow who worked for GE as a compliance officer, and he was asked, oh, so you make sure GE follows the laws? He said, no, I actually research how far we can push things before we are blatantly illegal and get caught. And these companies have fantastic resources to hire people like this. From the outset, when Medicare Advantage came available, I knew right away it was profitable for the insurance companies because I just looked at the amount of money they were spending on advertising. They wouldn't be spending this money on advertising if they weren't going to make, much more. I practiced dentistry for 41 years, and I came in contact with insurance companies that give me such a dim view. One of the most blatant examples was a patient who was a nurse at St. Clair's Hospital, was injured on the job. And basically her injuries and medication she was put on caused her to lose her teeth. She went through workman's compensation. The judge decided that she should have dental implants, and Hartford should pay for everything, the surgery, the crowns. I didn't do the implants, I did the crowns for her, the bridges, but it took 2 years to get paid by Hartford. They did everything in the book you can imagine to stymie, having to pay out the benefits. When you call people, you only get voicemail, you leave a message, never get a return call. They eventually shifted their call center to the Philippines where you can't understand anybody. And it took us months to get somebody's name. And they said, okay, you'll get the check next week. Never got the check. Call them back. And finally I had to get somebody's name and say, okay, you're telling, they wanted eventually all the records to show that it was medically necessary, but all that was already done in court. And the judge had already decided. I had to get their name and say, okay, Mrs. So-and-so, I'm going to tell Judge so-and-so that you said you need the medical records again. Would you like me to do that? I got a check next week. But it was 2 years of fighting with them.
For entertainment value, I would urge you all to look at the Arm and Leg podcast, because it is exactly stories like this. And what he covers in these stories is how people figure out how to fight back. And there are people that are literally what he calls insurance ninjas, who figure out how to fight back against the corporate power. It's sad that we have to have insurance ninjas to get the healthcare we need, but it's interesting because he brings up so many different aspects of the healthcare system that are outrageous in terms of charges, that are hard to negotiate, that are hard to navigate. If listening to that didn't make you into single payer advocate, you probably weren't listening. I really encourage you to listen to that, even though it's not about single payer as much as it's about how much we need it.
Yeah, I was going to mention that it probably never come to pass, but the only way to speed this up is to get all the members of Congress to have the same insurance that everybody else has.
That has been part of discussion in the past, yes. If they had to deal with the same things we have to deal with, there would be a lot more urgency.
Okay, talking about the arm and leg thing, Dr. Ray, if you could send me or Fred the list of resources you had on one of your slides towards the end.
Sure, I can just sure, yes, absolutely.
I will get that out to the membership and people that were on this today. Karen Kaufman had a comment. We're talking about the CT lung scan. Is that she said, every time I see a doctor, I'm asked if an ex-smoker I would like a lung scan. I say yes, and I've never been offered one.
Well, there are criteria, and I again, without knowing your medical history, it's for people who are over the age of 55, who are current active smokers and have at least a 30-pack year history of smoking. So, that's the Public Health Service recommendation for who is most likely to benefit from that test. So you may or may not fit those criteria. I don't know.
Okay, and one more comment here from Michelle Vicks. No one size fits all. That concept is obsolete.
Right. Well, the answer is that might be true for underwear, but it's probably not true for healthcare. The truth of the matter is we all have the same biology. We're all at risk for the same spectrum of medical illness, and so we all need to be covered for the same spectrum of medical illness. One size does fit all.
Mm-hmm. And a very good segue. I have no more questions or people with raised hands. One size fits all. So Medicare for all you're proposing would be a very good fit for all.
Yes.
Again, I thank you very much, Dr. Ray, for a very interesting presentation. Very informative and insightful. Thank you much.
Thank you so much for the opportunity. I really appreciate it. And if anybody wants to go to the CDHS website, which will be in the information that I'm going to give to Don, we'd be happy if you when you go to the website, if you ask to join and are willing to share your email, we'll put you on our email list and you'll know when we're having meetings or when we're having any programs. Thank you.